Thank you, everyone. And I apologize if I cough intermittently. I'm still recovering a little bit from a cold that I had. So thank you for the kind introduction, Dr. Black, and for being my mentor. None of the authors have any conflicts of interest to disclose. So this is the rough outline of what we're going to discuss today. So we'll go kind of quickly over some of the grand themes of when it comes to biology of metastasis and how that occurs. We'll also review the role of lymph node dissection in urothelial carcinoma, as well as the role of lymph node dissection in upper tract urothelial cell carcinoma. Now, metastasis is defined as a development of a secondary malignant growth at a distance from the primary site of cancer, and it's the hallmark of cancer that is responsible for the greatest number of cancer-related deaths, and is also a key cause of failure of cancer therapy, which eventually leads to patient mortality. It requires cancer cells to leave their primary site, as well to circulate in the bloodstream and also endure the pressure within blood cells and to thrive in that environment, as well to acclimatize and adapt to new cellular surroundings in a secondary site while escaping immune cell activation as well as destruction. So there's a couple of things that cancer cells will need to adapt in order for them to be able to do this. There are essentially kind of 5 key steps that have been outlined in literature that leads to cancer dissemination as well as invasion or metastasis into a secondary area within the body. The first step would be kind of invasion of cancer into surrounding structure, as well as intravasation of the cancer cells into nearby blood vessels or lymphatic vessels. And then circulation within the blood vessels or lymphatic vessels, and then extravasation from these luminal regions into secondary sites, and then colonization and eventually thriving in these areas and growing. Now, dissemination and invasion essentially requires chromosomal instability, which essentially is the initial trigger that leads to continuous errors in chromosomal segregation, especially during mitosis. And the activation of invasion and metastasis is triggered by numerous epigenetic factors as well as environmental stimuli. We have here some examples of these kind of environmental stimuli, such as extracellular membrane mechanical pressures, or kind of like soluble signals such as growth factors, cytokines, and chemokines, even like the microbiome of the area that the tumor is growing, as well as cell-to-cell interactions. There's hundreds of genes essentially that have been reported to determine the invasive potential of tumors. Some of them we will kind of see and report on, such as tumor protein or TP53, retinoblastoma genes. As well, we do know that metastatic cells tend to exhibit high levels of hypoxia-inducible factors, which allows them to essentially adapt to their cellular environment, especially in areas where there might be hypoxia. A key step, however, in metastasis is epithelial-mesenchymal transition, which basically is the loss of epithelial-like characteristics such as cell polarization. So cells are no longer oriented to kind of where they are. Essentially, it's kind of how I like to think about it. There's a high degree of differentiation also by tumor cells originally, and then they adapt into more invasive and migratory mesenchymal cells with properties that allow them to more readily migrate and disseminate. And this also allows them to, and all of these mutations also will allow them to resist stress as well. When tumor cells leave their primary site, they will then need to travel to a secondary site. And this secondary site is usually called a premetastatic niche. And this area is actually primed by the tumor before there is actual definitive metastasis. This is the premetastatic niche is the host microenvironment that is selectively primed by the primary tumor even before the initiation of metastatic disease. And this is a complex multi-step process that involves secretory factors as well as extracellular vesicles that induce vascular leakage, leading to more cells essentially entering that specific site, as well as extracellular modeling, as well as immunosuppression that allows the tumor cells to kind of break off and start developing there. Cancer cells, once they essentially go from these clusters of tumor cells, and once they enter the intravascular system, the circulatory system can be quite harsh for cancer cells. As such, they need to be able to resist the mechanical pressures within the blood vessels. They can kind of exist as single circulating tumor cells or CTCs, and they can also exist in CTC clusters, which are also kind of complex with platelets to help avoid immune detection and also to resist the mechanical pressure within blood vessels. Organs such as liver and bone, we know have highly permeable sinusoidal vessels, and these factors usually allow cancer cells to exhibit a high rate of metastatic deposits in these organs. So in prostate cancer, we'll commonly see them go to bone, for example. And extravasation and colonization of these tumor cells is a very complex process. It involves ligand and receptors, as well as chemokines and circulating non-tumor cells for that to happen. And essentially, it's thought that a process similar to how leukocytes extravasate into the endothelial region in cases of immune response, similar mechanisms are involved that allow for tumor cells to go into secondary kind of premetastatic niches or secondary metastasis sites. Now, metastatic organotropism is this clinical observation that most cancers will metastasize to specific target organs. We know for prostate cancer, it commonly metastasizes to bone and lymph nodes. And testicle, we know that we're quite familiar with the primary landing zones in testicular cancer, retroperitoneal lymphadenopathy, as well as bladder and kidney cancer, as well as various other cancers, all have kind of areas that most cancers will target specific other secondary organs. And this is a very complex interplay between the subtypes of cancer and host organ microenvironment, as well as cancer cell kind of interactions. There's quite a bit of crosstalk between cancer cells and their host organs, which essentially leads to formation of this premetastatic niche, leading to these specific target organs. And there's been now some newer studies demonstrating that maybe certain immunotherapies may be better targeted to certain, let's say in bladder cancer, if patients have more visceral versus non-visceral mets, there may be better different immunotherapy regimes that might work better. But again, these are all retrospective studies as well. We're just kind of beginning to look into this area of the idea of metastatic organotropism and what that might mean clinically for patients. When we specifically look at lymph node metastasis, there's a natural circulation of tissue fluid from the organs into the lymphatic system, which is why they tend to be one of the first sites of metastatic disease. Fluid dynamics play a pretty important role in the initiation of lymph node metastasis. Blood vessels are usually generally quite permeable, and tumor growth leads to essentially aberrant blood flow, as that leads to plasma accumulating in the extracellular sites, leading to impaired lymphatic drainage. This essentially leads to increased intratumoral interstitial pressure, where the extracellular fluid is not effectively drained due to the compression of local lymphatic vessels by the tumor. This favors the flow of interstitial fluid from tumors into the surrounding stroma, into areas of lower interstitial fluid pressure and lymphatics, leading to dissemination of tumor cells. And again, epithelial mesenchymal transition and loss of cell polarity is very important to allow for cells to kind of have this migratory characteristics. So why is lymph node dissection important? Sorry, excuse me. So looking at kind of the clinical staging of lymph nodes and detection of micrometastatic disease, many studies demonstrate that our current imaging modalities are far from perfect, and there can be very high false negative rates as well as false positive rates. Pathological lymph node dissection is the most accurate method of detecting lymph node metastasis, and the potential therapeutic benefits of accurate pathological staging, as well as potentially some therapeutic benefits of lymph node dissection, must be weighed against the morbidity of procedure, as we all know, such as damage to surrounding vessels, nerves, leading infection risk, venous thromboembolic events, damaging surrounding structures, as well as lymphoceles. There have been significant efforts to try and refine patient selection for lymph node dissection while optimizing staging and still making sure that we're treating micrometastatic disease. However, none of these have really found to be adequate or replacements for lymph node dissection. Now, focusing on bladder cancer, bilateral pelvic lymph node dissection is a standard part of patients undergoing radical cystectomy. But why is that the case? We know from several retrospective studies that examines outcomes for patients and for patients with nodal disease. They're known to have worse disease-specific survival when they have pathologically confirmed positive lymph nodes. This was a retrospective study at a large institution with a median follow-up of 10.2 years, and they found that the overall recurrence-free survival at 5 and 10 years for the entire cohort was around 66 at 10 years to 68% in 5 years. However, 5 and 10-year recurrence-free survival for patients with positive lymph nodes was only 35 to 34%. This was another retrospective review of over 1,000 patients undergoing radical cystectomy with pelvic lymph node dissection without neoadjuvant treatment, and they found that the 10-year disease-specific survival for lymph node positive disease was only 16.7%. So these studies demonstrate that pathological lymph node disease is associated with worse patient outcomes. When we try and look at how good we are with current kind of imaging modalities or conventional imaging, this is a systematic review and meta-analysis of 35 studies that looked at the ability of pre-op imaging to identify positive regional lymphadenopathy in bladder cancer patients who were then subsequently all treated with radical cystectomy and pelvic lymph node dissection. So they could compare the pre-operative imaging reports to the gold standard kind of pathological diagnosis to see if there was indeed a lymphadenopathy or not. Now, they included 20 studies that looked at CT, 10 on MRI, as well as 20 looking into PET-CT imaging. They found that the positive rates for CT scan for true positive lymph nodes was only range between 56 to 90%. However, there was a false negative pool sensitivity rate of 40%, meaning that in 40% of cases with a negative CT scan, patients may still harbor positive lymph nodes. They found that the pooled false negative sensitivity rate from MRI was 60%, and PET-CT scan still had a pooled false negative sensitivity rate of 56%. So this meta-analysis, the main takeaways that I took from it was that imaging can still often underestimate the extent of nodal disease, which is why it's still important to do lymph node dissection in patients undergoing radical cystectomy, even if they are clinical stage C and 0 disease with conventional imaging. Now, there were some reports of using essentially iron oxide IV particles that's injected prior to MRI to see if this will increase the sensitivity of MRI to detect pathologic lymph nodes. However, this has not really shown any significant clinical promise, and there's not really more recent data on it. When we look at the kind of what the boundaries of a standard pelvic lymph node dissection is, as we all know, the standard lymph node dissection template includes nodes in regions 1 and 2, including the obturator, the external and the internal iliac lymph nodes. The boundaries would be laterally the genitofemoral nerve, the bifurcation of common iliac artery cranially, and caudally the circumflex iliac vein, or some people will use the nodal cloacae, and medially the bladder or hypogastric artery and obliterated umbilical artery. In extended, you will include the presacral as well as pararectal lymph nodes, as well as up to the common iliacs. And super extended will include essentially the periaortic K1 lymph nodes, along with kind of the lymph nodes that is inferior to the inferior mesenteric artery. And these boundaries come from previous template mapping studies, one of which we'll review here. So this is one of the earliest template mapping studies for nodal metastatic disease in bladder cancer. They had 653 patients who underwent radical cystectomy with extended or super extended pelvic lymph node dissection without neoadjuvant chemotherapies, which is great, so you can kind of see the true extent of disease between 1990 and 2013. Interestingly enough, looking at this chart, we see that almost 60% of patients actually had clinical stage CN positive disease. Okay. So they kind of looked at what the rate of lymph node positivity was at these kind of separate areas. The standard, again, included the external, operated, internal nodes extended up until common, as well as super extended up until the IMA. They found that a total of 30% patients actually had pathologic nodal disease. Interestingly enough, this was approximately half of the number of patients who actually had nodal disease preoperatively. So CM positive disease on imaging compared to true positive was only 30%. They found that 90% of patients who did have nodal disease, or 172 out of the 653 patients, had disease within the standard template, and only 30 patients had disease in the extended, as well as only 21 in the super extended template. And they found that there were only 2 cases out of the 191 patients who actually had any nodal disease that has skip metastasis, meaning that they had no disease in the standard lymphadenectomy template, but however did have disease in the extended and super extended templates. So given this kind of early template study demonstrating that the skip lesions in bladder cancer is quite rare, it really begs the question, are extended lymph node dissections really necessary? So this is one of the first trials looking at if the extent of lymph node dissection in bladder cancer is necessary, or if there is a benefit to extended lymph node that compared to standard pelvic lymph node dissection in bladder cancer. And this was one of the first large phase 3 trials looking into this. This was a study based out of 16 centers in Germany, and these are all high volume cancer centers. They enrolled 401 patients across the 16 institutions, and surgeons all had to have mandated credentialing processes with intraoperative photos that were required, and they required that surgeons had to have completed over 30 radical cystectomies with more than 15 radical cystectomies per site per year. Main inclusion criteria were patients with locally resectable urothelial bladder cancer, CT1 to CT4A, with any kind of clinical nodal disease with no metastatic disease. Main exclusion criteria was anyone with who received previous neoadjuvant chemotherapy, previous pelvic radiation or pelvic lymph node dissection, as well with enlarged more than 1 centimeter lymph node above the aortic bifurcation. The primary endpoint was looking at time to progression, and it was essentially designed to show the study was designed and they did sample power calculations based on the study demonstrating a 15% disease-free or recurrence-free survival benefit at 5 years. Main secondary endpoint was overall survival as well as cancer-specific survival. And the limited here, again, looks at the operative internal and external nodes, whereas the extended included the standard template along with the common, the presacral, as well as pericaval lymph nodes, as well as interior cable, periaortic, essentially all the way up until the IMA. Now, they had, in the end, 203 patients in the standard arm and 198 in the extended lymph node dissection arm. They completed intention to treat analysis with the median number of nodes being removed in the limited group, 19, and extended groups, 31. Approximately 49% of patients had less than PT2 PN0 or less. Only only 25% of patients had PN positive disease. As well, we see that postoperatively, approximately 15 and 14% of patients got adjuvant chemotherapy. And most of the patients who received adjuvant chemo was for T3 disease or lymph node positive disease. When they looked at their primary as well as key secondary outcomes, unfortunately, there was no significant difference at disease-free survival at 5 years. As well, and the key secondary endpoint, cancer-specific survival, there was no significant difference. Looking at complication rate, there was slightly higher rate of lymphocyte requiring drainage for the extended lymph node dissection template, and that was statistically significant here. However, there was no other significant difference in overall complication. Overall, this trial called the LIA trial essentially demonstrated that there may be a trend potentially in favor of extended lymph node dissection. As you kind of see here, there is some early separation of the two curves. However, there is no significant complications other than more lymphocytes requiring drainage in the extended lymph node dissection arm. Now, there's a couple of reasons why the study might not have been positive. There's concerns about the study design. Some critiques of the study kind of stated that they believe that the study was originally designed to show 15% 5-year recurrence-free survival, which was quite ambitious. They also thought that inclusion of T1 patients might have led to the non-statistically significant design, since pelvic lymph node dissection is not routinely recommended in patients with non-muscle invasive bladder disease. They also excluded patients with any positive nodes, which are patients who may quite often benefit from extended lymph node dissection, as well. No neoadjuvant chemotherapy was given. Another thing to note is that they did an intention to treat analysis, and actually 25 or up to 12.6% of patients in the extended lymph node dissection protocol arm actually did not have a true extended lymph node dissection with less than 12 lymph nodes removed. So this might underestimate the clinical benefit of the external lymph node dissection. Now, fresh off the press, recently at the EAU, just a couple of weeks ago, Dr. Gershwin, who was one of the primary authors in the LIA trial, presented some long-term follow-up data on demonstrating essentially close to 5-year updates on the LIA trial. So this slide was kind of taken from Dr. Gershwin's presentation at the EUA, which essentially showed that time to progression at a median follow-up of 58.4 months, which was their primary endpoint. There still remains a bit of a stable difference between the extended and standard lymph node dissection arm, delta around 8%. However, this was not statistically significant. And their key secondary endpoint, overall survival, still there potentially is some stable difference, however, also not statistically significant. However, when looking specifically at cancer-specific survival, they did find that there was a difference of 12% within the extended and standard lymph node dissection at a median follow-up of almost 60 months. And this cancer-specific survival essentially demonstrates that the quality of lymph node dissection can have very important patient implications and can render them cancer-specific, and potentially can have cancer-specific survival benefits in this population. Now, this is another very...
Sandra, yeah. What was the hazard ratio?
The hazard ratio was 0.65.
0.65.
Yeah.
Thank you.
Yeah. So, and this is the SWOG S1011, our Vancouver General Hospital did participate in the study. This was another prospective randomized study that aimed to evaluate the importance of extended versus standard lymph node dissection. The results were originally presented at ASCO 2023, and Dr. Lerner also presented some unpublished data at the EUA, which I will also kind of touch as well. Sorry, in clinic here. This included 658 patients enrolled across 27 sites in Canada as well as in the United States. The primary endpoint was disease-free survival from time of randomization to first documentation of any relapse or recurrence or death due to any cause, and that's key. And I'll bring that up again when we talk about some of the outcomes. And this study was designed to show approximately 10 to 12% 3-year disease-free survival or overall survival benefit. And key secondary outpoint was overall survival as well as postoperative morbidity. Inclusion criteria required high volume centers with intraoperative photos. They did not include robotic cystectomy, which is the same for the LIA trial. Surgeons had to have completed over 50 radical cystectomies in the last 3 years, and the number of radical cystectomy in the hospital institution that participated needed to be over 30 per year. They included anyone with CT2 to CT4 disease, with CN0 to N2 urothelial carcinoma, and they also did subgroup analysis by patients who received chemotherapy with cisgem, which is standard of care, or other versus none. Of note, they did not comment in if patients got those stunts and back or not. They also looked into CT stage, looked into analysis, subgroup analysis by the pathological state, as well as patient performance status, and patients were randomized intraoperatively after essentially assessing that there was no evidence of any extravesical disease. Patients were randomized to standard versus extended lymph node dissection. The standard template was the same as the LEA trial, as the extended template included essentially nodes up until the aortic bifurcation, including common iliac, pre-sciatic, as well as presacral nodes. This is from Dr. Lerner's presentation at the EUA, and looking at some pre-randomization patient variables. They had 300 patients in the standard lymph node dissection arm and 292 in the extended lymph node dissection arm. Approximately a third of patients had T3 disease and above, so they were kind of locally advanced, and 25% approximately of patients had hydronephrosis, so putting them in a higher risk category. We see that approximately 57% of patients in each arms received neoadjuvant chemotherapy, and most of them were cisplatin based. And again, they did not specify if patients got those stints MVAC or not. Looking at some operative variables, they did find that the median operative time was longer with extended lymph node dissection. It added on around 20 minutes, and this was statistically significant as well. There was slightly higher estimated blood loss as well, with 600 in the standard lymph node dissection compared to around 700 cc's in the extended lymph node dissection. The total number of nodes that were removed, and with this study as well, along with the LEA trial, patients had to send intraoperative photos after lymph node dissection was carried out. In the standard lymph node dissection arm, there was a median of 24 lymph nodes, but that ranged from 6 to 61. In the extended arm, there was a median of 39 lymph nodes that were removed. Again, ranges from 15 to 59. 94 lymph nodes that were removed. There was no difference actually in the lymph node metastasis. So in the standard arm, 24%, in the extended arm, 26%. Again, I think this just demonstrates that how in bladder cancer, this is in line with previous studies demonstrating that there is a lack of significant skip lesions in bladder cancer, which is nice to see. And of course, as we would expect, since extended lymph node dissections were doing more aggressive lymph node disease, more patients had N2 and N3 disease. When looking at adverse events, there was extended lymph node dissection essentially had an increased grade 3 to 4 adverse events, 16% in the extended arm versus 8%, and they kind of lumped all of them together. The 30-day mortality for standard versus extended lymph node dissection showed that standard had 1 patient and extended had 8, and 90-day mortality showed that at 90 days in standard lymph node dissection, 7 patients had passed away, and in extended lymph node dissection, there were 19 patients who passed away. They did say, however, that in the extended arm, there were 6 patients who actually progressed from their disease. And because they did not specify this is all-cause mortality, not cancer-specific mortality, it's really hard to tell, if this is as a result of complications from the surgery versus just natural progression of disease. And in unpublished data, they also did look at recurrence patterns as well. Some adverse events specific, also looking at venous thromboembolic events, they did find that there was slightly higher rates. 28 patients had venous thromboembolic event compared to only 18 in the standard lymph node dissection arm. And when they carried out secondary analysis, looking at variant histology, urinary diversion type, they also looked if patients required blood transfusion. Overall, they saw no differences in disease-free survival or overall survival benefit at a median follow-up of 6.1 years. And these curves were presented last year as well as this year at the EAU. And some comments on this study. Although SWOG is, essentially demonstrated no disease-free survival or overall survival benefits for patients undergoing extended lymph node dissection compared to standard lymph node dissection, there are a couple of reasons why the study might have failed to show this benefit with the extended lymph node dissection, and the results of this study may not be applicable to all patients. Now, they did include patients who received neoadjuvant chemotherapy, and they haven't presented yet on essentially stratified survival and disease-free survival benefits by chemotherapy regime yet. But the inclusion of patients who did receive neoadjuvant chemotherapy may reduce the benefit of the surgical resection alone, especially in patients who might not have gotten a chance to receive neoadjuvant chemo or were not candidate for it. Patients with lymph node metastasis outside the pelvis were excluded, and these may be patients who might benefit from surgical debulking. Applicable to findings to patients with varying histology, they did allow for, the SWOG trial did allow for patients with predominant urothelial carcinoma with some minor components of variant histology, but for patients with predominant plasmacytoid or other high-risk kind of variant histologies, lymph node dissection might be more important for these patients. Mortality did not specify cancer-specific survival, so some of the 30 and 90-day mortality rate, especially inclusion of patients who progressed with their disease, might not be accurate. And of course, we can't, knowing that we are being observed, or the observer bias or Hawthorne effect may be quite real in both in the SWOG as well as Leo trials, with the median number of lymph nodes being removed in standard lymph node dissection being 24 up to 61, which is quite high. As well, the number of nodes that was removed by surgeon can vary by institution as well, given the fact that it really also depends on the pathologists who are kind of looking at the lymph node packets. It's interesting to note that Dr. Lerner did present some patterns of recurrence, and data find that local recurrence in patients with positive lymph nodes was around 30% in the standard lymph node dissection compared to only 12% in the extended lymph node dissection. So there may still be some benefit of extended lymph node dissection. And this is unpublished data, which is why I didn't put it up here. When we try and look at essentially the potential benefits of extended versus non-extended lymph node dissection in radical cystectomy patients, most of the literature, unfortunately, is based on large retrospective chart reviews. The prospective trials, the LEA and the SWOG trials are kind of the best that we have. This is a meta-analysis looking at 10 studies involving close to 4,000 patients who underwent extended versus non-extended pelvic lymph node dissection. There were quite a number of variables when it comes to the studies. Some patients received neoadjuvant chemotherapy, as we see here, differences in follow-up. So again, unfortunately, with these meta-analysis, garbage in, garbage out. But they did look into hazard ratios for recurrence-free survival, and that was available for 8 studies. And when they did kind of this pooled analysis, there was a trend that favored extended lymph node dissections for recurrence-free survival. Looking specifically at 7 studies that looked at the 5-year recurrence-free survival rate, there was a trend that favors extended lymph node dissection over here. Looking at disease-specific survival, they looked at 4 studies that involved close to 2,000 patients. After pulling the data, they did find a significant correlation between extended lymph node dissection that did favor disease-specific survival with a hazard ratio of 0.66. Looking at overall survival, however, they looked at 3 studies. There was great heterogeneity within the studies themselves, so there was no real correlation. So again, maybe potential some benefit of disease-free survival. And overall, when they looked at all of these studies, there was no overall differences in major complications in the short term, such as 30 and 90-day mortality as well. For local context, this was a retrospective study published in 2016, based out of our center here. A retrospective chart review of essentially 314 patients who underwent radical cystectomy between 2008 to 2013 was carried out. They there was 105 patients in the extended lymph node dissection arm, which were matched to 105 patients in the standard pelvic lymph node dissection arm. Standard was essentially defined as below the bifurcation of the common iliacs, and extended was involved the standard plus lymph nodes along the common iliac artery to at least crossing the ureter up until the aortic bifurcation or the inferior mesenteric artery. All patients were followed for at least 90 days, and the median lymph node dissection in number of nodes in the extended arm was 21 compared to 9 in the standard lymph node dissection arm. And when they looked at recurrence-free survival, there was no significant, as well as overall survival, there was no significant difference. However, when we look at estimated blood loss, there is pretty significant difference between the extended and the matched standard pelvic lymph node dissection arm, with a median blood loss, estimated blood loss of approximately close to a liter, and almost maybe a little over half that in the standard arm. As well, need for blood transfusion was clinically significant as well. So this study essentially maybe brought up to the demonstrates that potentially the extended lymph node dissection may lead to harm and not necessarily benefits. So looking at another study that looked specifically at patients who may benefit from lymph node dissection, this study looked at patients who only receive radical cystectomy with extended lymph node dissection who did not receive any adjuvant chemotherapy or adjuvant chemotherapy. And it's still thought that maybe there is a proportion of patients who may still be cured with radical cystectomy alone. The study was published in the British Journal of Urology in 2013, and they retrospectively did a cohort analysis of two prospectively maintained databases, one at USC and one in Switzerland at the University of Bern. And they looked at patients who underwent radical cystectomy for CN0M0 disease, but found subsequently to have clinically pathologically no positive disease. Now, this was a significantly older patient cohort with a median age about 70. And of course, you can imagine this is why they were not eligible for adjuvant chemotherapy. None of these patients received neoadjuvant treatment and all had negative margins. They found that the median recurrence-free survival was only 1.6 years in this population. And when they looked at 5 and 10-year recurrence-free survival, it was 32% and 26%. And this was looking at patients who actually have pathologically nodal disease. So the authors kind of concluded from this study that up to 25% of patients at 10 years follow-up with documented lymph node metastatic disease did not receive adjuvant treatment, but still were recurrence-free, meaning that the lymph node dissection might have been curative in these patients. Now, in the world of non-muscle invasive bladder disease, there is an ongoing study looking at essentially the role of lymph node dissection in non-muscle invasive bladder cancer. So we'll be excited to see what the results of this study might be. In upper tract urothelial carcinoma, there is unfortunately scarcity of well-designed prospective studies given the rarity of upper tract urothelial carcinoma. And so a lot of the kind of lymph node dissection ideas and paradigms is extrapolated from the data on bladder cancer. Now, guidelines routinely recommend lymph node dissection at time of radical nephrourectomy and or distal urorectomy in patients with high-grade upper tract urothelial carcinoma. And although approximately 25% of patients with bladder cancer will present with muscle-invasive bladder disease, it's known that up to 2/3 of patients with upper tract urothelial carcinoma will present with muscle-invasive bladder disease. And as we all know, it's quite difficult to diagnose the extent of local disease on pre-op imaging, as well as adequate tissue diagnosis can be quite difficult in this patient population. This is from the AUA. They recommend that for patients with high-risk upper tract urothelial carcinoma, that patients should be given lymph node dissection at the time of radical nephrourectomy or urerectomy. And also the EAU recommends that a template-based lymphadenectomy should be performed in patients with high-risk non-metastatic upper tract urothelial carcinoma. Now, how do we know where these lymph nodes drain into? So this is one of the original lymphatic mapping trials that was used to define the lymph node dissection templates in upper tract urothelial carcinoma. It was published in the Journal of Urology in 2015. This was a retrospective multi-institutional study looking at 73 patients with lymph node positive disease who underwent template lymphadenectomy during radical nephrourectomy. And they looked at anatomic locations of the tumor as well as number of lymph nodes that were positive as well. They used descriptive statistics to kind of describe the lymph node landing zones. So kind of this is the image from the previous study, and this is kind of adapted to make things, to kind of look at things a bit easier. But essentially for renal pelvis tumors, it's recommended that dissection of nodes from the ipsilateral great vessel, so IVC, for the right-sided and aorta for the left-sided, should be carried out from the renal hilum to the inferior mesenteric artery right here. And based on clinical judgment, E2 aortic cable lymph nodes can be removed for right-sided tumors right here. For proximal and mid-ureteric tumors right here, dissection of nodes up until the ipsilateral great vessel and renal hilum and aortic bifurcation is recommended. So here and here for right and left-sided template-based lymph node dissections. And for distal ureteric tumors, dissection of the external iliac and obturated node packets at a minimum should be carried out right here, as well. Common iliac and internal iliac nodes should be done based on clinical judgment. This was another retrospective study that aimed to determine the rates of lymph node involvement in patients with upper tract urothelial carcinoma. They used the SEER database in patients with non-metastatic upper tract urothelial carcinoma who underwent radical nephrourectomy as well as lymph node dissection. They included almost over 2,000 patients, which is one of the largest studies to date looking at lymph node patterns of lymph node metastasis in patients with upper tract urothelial carcinoma. Excuse me. Now, given the fact that this is a SEER database, this was a retrospective study, so no conclusions can be really made about the extent of lymph node dissection as well as the quality of lymph node dissection. However, given a large database, there's that benefit of the large number of patients that were included. Now, interestingly enough, when we actually look at gender, there's almost a half split between patients who are male and female, which is not what we would normally expect. So I thought that was kind of interesting, since based on literature, we'd expect twice as males to have urothelial carcinoma as opposed to females. And we see that, of course, as we would expect and want, most patients had high-grade disease, so over 80%, because nephrourectomy should not routinely be done for low-grade disease. Overall, they found that 33% of patients did harbor lymph node invasion. As expected, lymph node invasion, the rates of lymph node invasion increases with clinical T stage. And they found that lymph node invasion was most commonly seen in renal pelvis tumors compared to ureter. And when they try and look at the evidence to support lymph node dissection, most of the evidence comes from this. Some of the evidence comes from this meta-analysis looking largely at retrospective data. Now, overall, looking at the four studies that reported on recurrence-free survival, as well as cancer-specific survival and overall survival, there was no significant improvement in patients who received lymph node dissection for upper tract urothelial carcinoma. However, when they focused on two studies that only included patients with high-risk disease categories, so PT2 and above, the recurrence-free survival did seem to favor lymph node dissections. And these two studies included over 500 patients. As well, they looked at recurrence-free rates at 3 months, essentially. One of the kind of only prospective study that looked into the role of lymph node dissection upper tract urothelial carcinoma is a study based out of Japan. They essentially looked at patients who underwent a radical nephrourectomy along with template-based lymph node dissection, and these are the templates for renal pelvis cancers. If they have cancer up to upper 2/3 or distal 1/3 ureter of the ureter. And they compared these 77 patients to a control group of 89 patients who did not receive lymphadenectomy during the same study period. Now, patients were not offered lymph node dissection if they were over 75 or had significant comorbidities. So these are some significant confounding variables. When they focused on patients with pathological T-stage disease, because when they included all comers, there was no real significant benefit in all of these factors. They defined that there was statistical significance for 3-year overall survival and cancer-specific survival favoring lymph node dissection compared to no lymph node dissection. However, disease-free rates, which I would argue is the most important thing when looking at the study, particularly, especially given the fact that they kind of cherry-picked the patients who would be receiving lymph node dissection, was not statistically significant, and there was no significant difference in patients with distal ureteric cancers. So in conclusion, kind of my thoughts are that that lymph node dissection is the most accurate method for detecting lymph node metastasis. And standard lymph node dissection should be carried out for patients with muscle-invasive bladder cancer with no evidence of extravesical disease or clinically enlarged lymph node. And this is going by the SWOG and LEA trial inclusion criteria. However, it should be noted that some patients may still benefit from extended lymph node dissection, and it will be really interesting to see once the final results from the SWOG trial is released. And specifically in upper tract urothelial carcinoma, lymph node dissection is recommended, given the high lymph node positivity rates, at least 33% in high-risk disease. However, again, very kind of poor evidence to support it, other than, it may help patients qualify for adjuvant chemotherapy and give accurate pathological diagnosis. And so that's the end of my presentation. I'd like to thank everyone for tuning in as well. Thank you to Dr. Black for kind of helping oversee this presentation.